Everyone. I hope you're enjoying this GI Onc 101 series so far. Nina Sanford from UT Southwestern in Dallas, Texas. Today we'll be talking about pancreas cancer. So I do think there have been several advancements, many advancements in the management of pancreas cancer, but clearly we have a long way to go. So I guess in the next 15 or 20 minutes, I'm going to try to give an overview of how we diagnose and treat pancreas cancer in 2025, but also talk about ongoing studies, things coming down the pipeline that hopefully will improve outcomes for patients with pancreas cancer in the future. So let's go ahead and get started. So first up is diagnosis, and this is, I think, a little bit more nuanced than in other disease sites, but the number one way to get tissue is with an EUS-guided biopsy. We prefer a core over a fine needle aspiration because with a core biopsy, you can get NGS testing, whereas FNA is really just yes or no cancer. But of course, to do a core biopsy, a larger bore needle is needed. So you really have to have a window of access, and that window has to not traverse or potentially traverse a critical blood vessel. So sometimes it's a game time decision made by the advanced endoscopist. I'd say much lower than an US guided biopsy would be an ERCP if a patient is getting biliary drainage or stenting. And during that procedure, you can get brushings for cytology. The yield is lower, probably about 30%, and this is really only applicable for pancreas head tumors. And then much less lower on the list would be a CT guided biopsy. We rarely use it. The risks are higher. It's a more invasive procedure. What about histology? So by and large, these are adenocarcinomas, greater than 90%. You do see adenosquamous and squamous cell cancers. These are much more rare. Generally, we treat them the same, but their prognosis is thought of as worse. What additional imaging do you need? So for the primary tumor, we recommend a pancreas protocol CT scan, which is you have to have contrast, and this is done in 3 phases from injection. You need thin slices, 0.5 to 1 millimeters. What do you want to see on the scan? So you obviously want to know the tumor size. You want to know where it's arising from the pancreas, whether it's a head uncensored process tumor, a body or tail tumor. You want comment on whether the tumor is leading to narrowing of the pancreas duct or of the biliary tree. And sometimes you can spot that with resultant upstream dilatation. You want to know if the tumor is invading or abutting the major vessels. The arteries that are important are the SMA, the celiac, the common hepatic. You want to comment if there are any anatomic variants. And then the venous structure, the portal vein SMV, you want to know if there's thrombus, if there's collaterals that have built up. When to use MRI. So this is not our first go-to diagnostic imaging, but we do use it in cases where a tumor is not well seen on CT, if the patient can't get contrast for CT, or to better assess the liver. For all pancreas cancer patients, you need to get full body staging. That's usually done by a CT scan. A PET CT or PET MR are done on a case-by-case basis. What about labs? CA19-9, that's a main tumor marker for pancreas cancer. You want to check that in the setting of a normal bilirubin because biliary obstruction can falsely jack up the CA19-9, so you don't really have a baseline unless you've done it after the patient is stented if needed. In 2025, all patients with diagnosed pancreas cancer should get germline testing with a comprehensive panel for hereditary cancer syndrome. Some are listed here. If a patient tests positive for them, then they should get genetic counseling. Technically for stage 4 only, but we are doing it for other stages. You want to get NGS testing. There are several actionable fusions, mutations, amplifications. You want to get the tumor mutation burden and mismatch repair status as well. Other things very important to think about in patients with pancreas cancer patients. I already mentioned a stent if they have biliary obstruction. Nutritional support is critical. Unfortunately, pancreas cancer patients have one of the highest rates of cancer-related cachexia. And then, of course, with a primary tumor in the pancreas, their pancreatic enzymes may not be functioning or their pancreas may not be secreting enzymes. So you want to get dietary nutrition counseling early in the disease course. And then diagnostic laparoscopy to look for peritoneal disease. We don't do this for all patients, generally just those with more high-risk features. If they have questionable imaging findings, a large tumor, an elevated CA19-9, a lot of nodes involved, Generally, at our institution, we tend to reserve this for patients with locally advanced disease. All right, let's talk about how we define resectability. This is very important, obviously, because it determines whether or not a patient can go to a surgery, but also the potential role of radiation, also sequencing of chemotherapy. So for all non-metastatic cancer, you have to categorize the patient based on their resectability. So there are specific criteria for this, which I will touch upon. But briefly, how I think about it is a resectable cancer is one where you look at the tumor at diagnosis on scans, and there are clear fat planes between the tumor and the adjacent vessels and organs. And a surgeon looks at it up front and they feel like they can take it out without leaving anything behind, R0 resection. In contrast, for borderline resectable tumors, upfront resection may be achievable, but it's likely going to leave behind microscopic disease or an R1 resection. And locally advanced means that the tumor is unresectable without leaving a chunk of the disease, R2, an R2 resection. The technical definition of resectability depends on the number of degrees of arterial and venous involvement. Here are the NCCN criteria, which I'll leave here and not go over in detail. But generally, arterial involvement is thought of as more severe or a higher degree of irresectability because these are harder to reconstruct with surgery. All right, let's talk about management. And I group this based on resectability status. So for resectable tumors, there are really, I would think, two current standards of care, either upfront surgery or perioperative chemotherapy. There are two ongoing phase 3 randomized trials comparing these strategies, one in the US, the Alliance trial, and then PREOPANC in Europe. The NORPACT-1 trial was a phase 2 randomized trial that showed no OS difference, but there are some caveats of the study. I think these two trials, phase 3 trials, which are, I believe, almost done occurring, hopefully will answer the question definitively. What do we do in practice? So I think there's variation, which is a theme you'll hear over and over, but some institutions, I think a lot of academic institutions are leaning towards initial chemotherapy for most patients. Others reserve that for patients who may be at higher risk for occult mets, high CA19-9, large tumor, et cetera. What chemotherapy do you choose? So basically for all stages of pancreas cancer, the first-line chemo is FOLFIRINOX or Gemabraxane for about 6 months. Adjuvant FOLFIRINOX was established based on the PRODIGE-24 study, showing better overall survival as compared to GEM. SWOG S505 compared periop FOLFIRINOX versus Gemabraxane actually showed no difference. So I think there is some degree of equipoise. That's why those are both first line, but generally FOLFIRINOX is for the better performance status patients. If a patient is less fit, we're talking ECOG 1, 2, then you can do a doublet chemotherapy regimen with FOLFOX or FOLFIRI or GEM with or without CAPE. What about the role of radiation? So I'll preface this again by saying that practice patterns vary quite widely. So some institutions use radiation for almost all cases of non-metastatic cancer, some use for almost none. I'll present a framework which I think is reasonable based on the available data. So for resectable pancreas cancers, I'd argue there's no role for the routine use of radiation, but we can consider post-op radiation if there are risk factors for local recurrence. And what are those? Close margin, LVI, and depending on the nodal status. So RTOG 0848 was presented last year. This was a phase 3 randomized trial. Patients had surgery for a pancreas head tumor. There had 2 randomizations, GEM versus gemcitabine, and then relevant this chemo versus chemoradiation. The study was negative for all patients, but there was an interaction by nodal status in that patients who were node negative, the median OS and DFS was improved with chemoradiation. The hypothesis being that if you're node negative, then you have a lower risk of distant, higher risk of local recurrence. So adding on an additional local therapy may translate to an overall survival benefit. All right, let's talk about borderline resectable pancreas cancer. These patients need to start with chemotherapy, again, FOLFIRINOX or Gemabraxane. The next steps, I think, really depend on what the restaging studies show, scans and CA19-9. At our institution, we will add pre-op radiation on a case-by-case basis if there is a continued risk for an R1 resection. And we we take into consideration arterial over venous involvement for that. What studies do you need to know? And I list 2 here and 3 on the next slide. These are more sort of radiation-based because I think this is an area of controversy when to add radiation for these patients. So I do think it is important to know what the data show or don't show. So let's start with the Alliance trial. This was published in JAMA Oncology a few years ago. This was a phase 2 randomized trial. The arms were neoadjuvant FOLFIRINOX with or without SBRT. So OS was numerically worse with SBRT. You'll hear that. But important to note that the trial was a pick the winner design, meaning it was meant to compare against historical data, not between the 2 strategies. So I think while the study clearly doesn't demonstrate efficacy or superiority of using SBRT for all borderline cases, I don't think anyone can really explain why SBRT itself could worsen the survival. Other considerations, randomization was at the time of enrollment. We know that between enrollment and end of initial chemotherapy, a lot of patients will develop METs. And even though it was randomized, there was imbalance in the arms with higher CA19-9 and more frequent dropout in the SBRT group, so that arm was closed early due to futility. PREOPANC-1. So this was a phase 3 randomized trial comparing upfront surgery with adjuvant GEM. That was a control arm versus neoadjuvant GEM with hypofractionated radiation, 36 gray in 15 fractions. That is a PREOPANC regimen. I'll talk more about that later. It included borderline and resectable patients. I include it with a borderline section here because the results were only significant in that subset. With the whole group, OS was longer with long-term follow-up. 5-year was more than triple, 20.5 versus 6.5%. The main limitation, of course, is the gemcitabine chemotherapy. All right, PREOPANC-2 was a direct follow-up to PREOPANC-1. It took the winning arm of PREOPANC-1, neoadjuvant GEM with hypofractionated radiation, and compared it not to upfront surgery with adjuvant GEM, but to neoadjuvant FOLFIRINOX. So the results, I think, were shocking in that there was no difference in overall survival. In my opinion, at least in the US, this trial is massively underrated. I think the fact that GEM with radiation conferred the same overall survival as FOLFIRINOX is surprising, but we need to take that for what it is. And some might argue that GEM radiation should be used in all cases based on that study. It's less toxic and it's also cheaper than FOLFIRINOX. Of course, the main limitation is that radiation arm did not use FOLFIRINOX. Though one might expect if they did and added it to GEM and radiation, that this would beat neoadjuvant FOLFIRINOX. But of course, that is a hypothesis that needs to be tested. All right. SPAC-5F, this was a phase 2 trial. It's a small study, but you may hear about it, so I think it's important to talk about. There were actually 4 arms, even though the trial only had 90 patients. One arm was immediate surgery, and then there were 3 neoadjuvant arms, 2 with neoadjuvant chemotherapy and 1 with neoadjuvant chemoradiation. The main finding was that survival was the worst with upfront surgery, and only 14% had an R0 resection, and best with the initial chemotherapy regimens. Limitations, as I mentioned, this was a small study, so I think it's hard to draw a conclusion, specifically with respect to radiation, because in practice, you wouldn't just give neoadjuvant chemoradiation without any induction chemotherapy. Okay, the last trial I think you need to know about for borderline is the PANDAS-PRODIGE study, which was presented but not yet published. Phase 2 study, it's important because this takes the best chemotherapy with FOLFIRINOX in both arms and then compares that to adding or not adding chemoradiation. There's no difference in OS or R0 at the time of presentation. The follow-up was short, but among patients undergoing resection, so that subgroup, the median OS was improved from 3 to 4 years, and the pathologic complete response rate was close to 30%. So obviously, we need to wait for the published results, perhaps long-term follow-up, but I think this is an important study to know about. All right. Moving on to locally advanced. These are unresectable tumors. So induction chemotherapy is always standard of care. You don't want to attempt surgery, of course, in these patients. And then I would consider consolidative local therapy with radiation for patients who continue to have local-only disease, particularly in those if they're having local symptoms or difficulty tolerating chemotherapy. Ideally, you want to see a CA19-9 drop the same way you would select for patients for Whipple. That being said, and that is our practice, based on current level 1 evidence, There's also equipoise for observation, continuation of chemo, based on the current data, which I'll talk about. So what are the studies you need to know about? There are two phase 3 randomized trials that use standard chemoradiation doses, and they were negative. LAP-07 and the CONCO-007 study, their designs were similar. Patients got initial 3 or 4 months of gemcitabine chemotherapy. Then they were randomized, either continuation of chemo or chemoradiation. The LAP-07 study showed no difference in PFS or OS, though chemoradiation decreased time to local progression and time next therapy. CONCO-007 was negative, including for R0 resection rate, which was their primary endpoint after they had slow accruals and initially OS. That study actually hasn't been published yet. So that is with standard low dose chemoradiation. There is signal of benefit or suggestion of benefit if you go to a higher dose in single arm studies, but the caveat, of course, is that these are non-randomized. So the two major studies that have paved the way for this thinking is from Memorial Sloan Kettering. They treated patients with two regimens approaching a biologic dose of 100 gray, either a 15 or 25 fraction regimen. They tend to use a more protracted dose. The median OS from the end of radiation was 18.4 months. And then the phase 2 SMART trial, this is MR-guided adaptive radiation, that showed a promising 2-year overall survival in this disease of 27% for locally advanced disease and no grade 3 or higher toxicity attributable to radiation. So that brings us to NRG-GI011, which is a randomized trial of dose-escalated radiation in locally advanced pancreas cancer patients. And the acronym or the nickname is LAP-100, based upon the target biologic effective dose of 100 gray. So I want to put out a plug for this study. This is our study coming out of NRG. This is for patients with locally advanced pancreas cancer who get initial chemotherapy. They don't progress. They have to respond biochemically with a drop or normalization in CA19-9 with absolute value less than 100. And they are randomized to either dose-escalated radiation or standard of care, which can be chemotherapy, observation, or low-dose chemoradiation at the choice of the team, of their physician, of the patient, based on the studies I presented. The primary endpoint is 3-year overall survival. Dose-escalated radiation can be accomplished in 5 or 25 fractions. MR or CT-guided radiation is permitted. You get adaptive or non-adaptive. And for every patient in the high-dose arm, the dose-escalated arm, we're doing real-time radiation quality assurance. So this study should open in the next couple of months. If you are a cooperative group enrolling site, I would encourage you to consider opening and enrolling on this trial. I think it hopefully will answer an important question. If you have any question about the study, please reach out to me. Okay. Other things that I want to talk about. So systemic therapy, I already talked about this a little bit. For fit patients, the first lines are FOLFIRINOX or gemabraxane. There is also a regimen called NALIRIFOX, which uses liposomal irinotecan. I put an asterisk here because I want to talk a little bit more about it. The approval for that is based on the NAPOLI-3 trial, which compares NALIRIFOX to gemabraxane in the metastatic setting. So limitations are that it is compared to gemabraxane, not FOLFIRINOX. It's in the metastatic setting. The drug is a lot more expensive. So when talking to medical oncologists, some actually never recommend it. Some will recommend it for patients who had poor tolerance to FOLFIRINOX, or if they have renal impairment or neuropathy, because the dose of oxaliplatin is lower in the NALIRIFOX regimen than the FOLFIRINOX. If a patient has worse performance status, then we typically use a doublet chemotherapy, FOLFOXIRI, or gem and/or capecitabine. Now, if they have a BRCA or PALB2 mutation, then we tend to also recommend GemCis because these mutations render tumors more responsive to cisplatin chemotherapy. Okay. What about oligometastatic cancer? So oligometastatic cancer means metastatic cancer, but with limited sites of spread for whom aggressive local therapy may confer benefit. The best data for this in 2025 is from a phase 2 trial from MD Anderson led by Ethan Ludmere that randomized patients to chemotherapy with or without ablative radiation if they had 5 or fewer metastatic sites. The study showed that the addition of radiation improved progression-free survival from 2.5 to 10.3 months. There's no toxicity. Survival is the same. This is now going to be a phase 3 trial with a larger number of patients that will hopefully address this question definitively. Other things to talk about. Celiac plexus radiation. So because the location of pancreas tumors near the celiac axis, as they grow, they can compress the nerves and cause pain that can really be very, very severe, intractable, resistant to narcotics. We know that radiation can be very helpful for these patients, either 25 gray in just one fraction or over 3 fractions, lower dose per fraction. When I treat these patients this way, I'll treat the whole celiac axis and also the primary tumor. So just something to consider if you have a patient with this type of pain, radiation can really, really be helpful, potentially be helpful. Okay. One more thing. So patients with local recurrence or patients who are medically inoperable, meaning their tumor is resectable, but they are not a candidate for surgery. These are scenarios where radiation can be beneficial, and there is single-arm data showing that it can help. Either symptoms or progression, potentially prolong survival. Of course, in this scenario, like other scenario, we need to carefully weigh the patient's performance status, whether they've had prior treatments or symptoms and goals of care. And hopefully we'll have studies down the line showing the role of radiation in those settings. All right. Okay, taking a breather. Just a couple slides as I end these presentations on more radiation-specific things. So again, feel free to tune out if you're not a radiation oncologist, but here is how I think of the details with regards to SBRT or SABR radiation planning. And this is just for SBRT SABR, not the conventional chemorad. So simulation, these patients need to be NPO. You need to get a scan with contrast. We use triple phase scans. Oral contrast is plus minus. It does help aid in seeing the duodenum, but you don't want to overfill because remember, they're going to be NPO for treatments. I tend to give a small dose, a couple sips, 100 cc's of water or contrast, depending on if it's MRCT, right when they're walking into the scanner. Motion assessment is critical. And then if there's more than 5 millimeters of motion, if you're doing high dose radiation, you really need some sort of motion management. For CT-based treatment, we recommend fiducials. You can use metal stents as a surrogate, but those can be less reliable. And then if you are doing CT-based treatment, we recommend fusing with an MR or PET as needed. All right. What about target volumes in radiation? Another area of controversy. I think the high dose is pretty self-explanatory. There should be gross tumor. We typically include adjacent vasculature within like 5 millimeters. And then I also include this term hazy gray, evil gray. I take that from the head and neck literature. This is basically pancreas tumors are not always well circumscribed. You may see a tumor and then near it, areas of like wispy gray, that has a high chance of harboring malignant cells. You want to include that in the high dose. What about the elective area? So I think in 2025, most quote unquote experts would agree that some extent of elective coverage is needed, but that this should really emphasize not sort of the post-op large nodal beds, but the at-risk vasculature, and that's based on patterns of recurrent studies. There are essentially 2 ways to accomplish this. One is what I think of as anatomically tailored elective coverage, basically thinking about where the routes of spread are. We published an NRG contouring atlas looking at this, so that goes over step by step our elective coverage recommendation in detail. So I recommend you taking a look at that if you are someone who treats pancreas cancers. And the nodal volumes are really emphasize vascular areas and something called a triangle volume. Another way is the pre-opanc style, which is basically the GTV with a large margin, and the margin is large enough that it essentially encompasses most, not all, of those areas. That being said, recall that the pre-opanc dose is lower, so blind expansion is safer. That's probably not safe if you're doing this sort of dose escalated BD to about 100 gray. Okay, last slide, margins. PTV, we use 3 millimeters for adaptive, 5 millimeters non-adaptive. Our PRV is 1 to 5 millimeters. What about dose? So I've talked about this a little bit. I think it does depend on the scenario you're in. If you are treating pre-op, Post-op microscopic disease, you may not need a as high dose, but if you're treating in the locally advanced setting and radiation is the only local modality, then you probably need to try to dose escalate it. And many now believe the ablative threshold is about 100 gray, at least 70 gray, but probably closer to 100 gray. Off trial, our regimen is, I'd say 40 and I'd say 40 to 50 gray high dose and 25 gray elective in 5 fractions. In lap 100, it'll be 50 and 33 gray. But there is a range of regimens. As I mentioned, Memorial uses 15 and 25 more protracted regimens. And recall that Preo-Panc used 36 gray and 12, but that was not for gross disease. That was in the preoperative setting. What do you need to know about OARs? So of course, the highest risk organs are the luminal structures, the stomach, duodenum, and small bowel. We generally try to restrict the high dose in those areas, and these are the constraints we have in our energy atlas. All right, so that's what I got for pancreas cancer. Sorry, that was a little bit fast. Obviously, a lot more I could say. Hope that was helpful. If you have any feedback, of course, I've gotten a lot that has been helpful for these videos. Please feel free to reach out to me. Thanks again.